Welcome, friends. This is Dr. Jaitly, your cardiologist from New York. Here I am on MuniMeterHealth, your favorite video channel, which is being shown on several social platforms, primarily to improve the medical education to the medical fraternity. That's the medical groups of cardiologists, the colleagues, the residents, the fellows, and of course the medical students, and patients' education as well. So this way we can enhance the clinical outcomes in our patients across the board, and that has been my global initiative all across in my practice, and therefore I'm now translating all of that into this site, which is MuniMeterHealth for you. So welcome again. Without any further ado, I'd like to delve into the subject matter. Today we're going to be discussing TAVR related strokes and how do we prevent them. So related CVAs we call them, or strokes. And, we know that TAVR is the Transcutaneous Aortic Valve Replacement, which is a recent procedure, recent technique in the past, I would say about 7 to 10 years. And, of course, the pioneering work has been done right here in New York City and, of course, across the world and throughout the United States. Just so that you know, basically the principle is to try and pass a catheter, which I will say like this in a different color form here. The catheter, which is called the TAVR deployment catheter, it comes right into the aortic valve right here. And as it approaches, the valve is sitting right here. So as a result, now you can deploy the valve, which will look more or less like this, if you will. It'll have a nice little mesh here. It's a metallic mesh, and the contents are now more advanced, and they are, in fact, it's called the Edwards Sapien 3 valve, or many other companies are doing it, but Edwards Sapien, say, if you're talking about, so that has a prototype a pericardial bovine tissue valve, which is very, very durable. It has low profile, and of course tries to match with the aortic valve here per se. Now remember, the aortic valve per se, you would like to do that only when there's tremendous aortic stenosis. The green I'm showing is the aortic stenosis that is present in these patients. Many times there's a lot of calcium here. So these valves, what you insert transcutaneously, which is great and not a surgical technique. So obviously there are clear advantages here with the TAVR. Well, number one, it's a minimally invasive procedure, if you will. Okay, so minimal invasive procedure, no surgery involved, obviously, and no GA involved, no general anesthesia involved, and the recovery time is excellent because you could be home on the third day. Okay, which is pretty good. And straight from the cath lab, the patient may be advanced into the recovery room for a couple of hours, and then to the regular floor or regular ward, and then just watched on telemetry for a couple of days, and you're home. Very seldom, or now less than 20% of the patients, I should say, they go into the ICU post-op care, maybe for a day or two, depending upon their conditions. Most of these patients, remember, they are surgical high risk, so that's an indication here. So you have to be a surgical high risk, because otherwise, if they were low risk, you'd still continue to do the surgical AVR in those patients, which is the surgical technique. That's the other alternative to the TAVR, which has been around for a long time, obviously. TAVR is only there for less than 10 years, if you will. Okay, and so the kind of valve that's inserted looks more like this, if you will. I can show you. This is the magnified version of this valve, if you will, and then it has this metallic mesh, or we call it a jacket, and the structure is made of bovine pericardial tissue, rather, I should say, and this mesh is the jacket, and that's the metallic jacket. And these are very low profiles. In other words, they are small, they are not that tall, they are very short, and they could fit into almost anybody's arch of the aorta, the aortic arch, and in pretty much all body surface areas. So they come in, and the type that we're talking about is the Edwards Sapien 3, which is the kind of the valve you're talking about. So anyway, so this is your left ventricle, this is your left atrium, just to make it a schematic here for you, and these are your mitral valves. These two are your mitral valves. So again, the left ventricle, obviously the blood is flowing in this direction, and as the blood is flowing into this direction, it goes up into the aorta. While you're putting the catheter, which is the TAVR deployment catheter, we call it TAVR deployment catheter, that is putting the valve in, there are several showers of microemboli which are flying into these great vessels, we call them. These are the brachiocephalic, if you recall, the right brachiocephalic. This is your left common carotid, and this is your left subclavian artery. Okay, so that's the left subclavian artery. So these are the two great vessels which are going to the right side of the brain and the left side of the brain here. Obviously, this divides into two, and one becomes the right subclavian, this one becomes the right common carotid. So, long story short, these great vessels, especially going to the brain, the either side of the brain, they suffer emboli. And currently, the stroke incidence is about, unfortunately, still about. Despite the TAVR, the stroke incidence is still about 3 to 6%, depending upon the medical centers you're looking at. So the goal is to try to reduce the stroke incidence as much as possible in order to justify this TAVR in these surgically high-risk patients, because they are surgically high-risk patients as is, and the last thing you want is give them a valve, and the next thing they end up with a stroke, so they can't even move. So it is terrible that you have a stroke incidence still about 3 to 6%, which is comparable to the surgical procedure, the surgical valve. So the goal is now to reduce it. And along came this new accessory device, which is now called as Sentinel. It is called Sentinel Cerebral Protection System. Okay. And I'm writing in a rush, so just remember that. This is my handwriting here right now. So Sentinel, it's called the Sentinel CPS, or we call it the Cerebral Protection System. Now that has been approved by the FDA, and only in summer of 2017, just a few months ago. So this is a wonderful procedure, and the way it works is it's basically a dual filter. So what are you doing? You're actually filtering all the showers that I just showed you right here, which were happening. You actually filter it, and the way you do that is by inserting a catheter. Now we're going to show a catheter here, which is going to pass through your right subclavian artery, and it's dropped here into the right brachiocephalic, and then it just arches up here and goes into the left common carotid, right up to the mouth here. That's all. Okay, it doesn't have to go all the way up. Now you have what it looks like is more of a filter, if you will. So it'll allow the blood to pass through, so that this way none of the carotids are obstructed, and it opens up almost like a fishnet or an umbrella, if you will. And as a result, now it's catching all these microemboli. And when it's catching all these microemboli, what has happened is the incidence of the stroke has dropped now to less than 1%. Now that's remarkable in a trial that was just shown, headed by the Columbia Cornell team, and it's called the Sentinel trial, as a matter of fact. And the investigators were between the 19 hospitals, and there were about 363 patients, and 19 hospitals they participated. And this FDA new accessory device, which is called Sentinel Cerebral Protection System, that just got approved, SCPS. And in fact, that accessory device has reduced the stroke incidence to less than 1%. Now that is remarkable, especially in a setting now with the TAVR that's now increasingly being performed, as opposed to a surgical risk, which still remains 3 to 6%. So obviously in a surgically high risk patients, now you can advise TAVR along with this accessory device called the Sentinel Cerebral Protection System, which is a very novel idea to catch all these microemboli before they are brain bound. So all these brain bound, in fact, they showed that when they actually removed this catheter, because this catheter has to be removed. Once this catheter has to be removed, and likewise this catheter is also removed after the deployment of the TAVR. So when this catheter was removed, they looked at these fishnets, if you will, or the filters, and they found all these debris of emboli, and 99% were headed to the brain. So all this 99% was of these were caught here, right there. So that's a pretty tremendous advancement now in the past couple of years, and now that this device is FDA approved, it is being used as an accessory, an accessory device on a platform where you are indicating a TAVR for all your patients who are surgically high risk, would otherwise have gone for surgical AVR, but the problem is they could not sustain the surgical high risk, which was prohibitively and exorbitant, and as a result now the TAVR has really taken over in terms of especially for the high risk patients. So I thought I'll just do a quick video on this new device called Sentinel Cerebral Protection System. I thank you for your attention, and I hope we are trying to keep you as current as possible with the newer videos that are coming down the pipeline. And of course, we are still sticking to the basics of cardiology and human heart awareness, both for medical fraternity and the patient care as well. So stay well, and of course, stay on MuniMeterHealth, your favorite site for human heart learning. Thanks again, and this is Dr. Jaitly.